clinic on Wisconsin Avenue Northwest near the Friendship Heights Metro seeks to partner with primary health care and major employers to reach individuals in early stages of illness. And with that, I would like to switch over to Johnny.
Good morning, everyone. If you can see my screen, first of all, I want to thank Lakeview for this opportunity. They are a cutting-edge facility, and I have enjoyed sending people there in the co-occurring side of our business, people who are looking at the whole person and really doing a wonderful job with the science and with the traditional supports, both before and after treatment for addiction illness. And I want to thank all of you in this workshop right now for your interest in this subject. I have been a spokesperson for mainstreaming addiction illness for many, many years now. When I say mainstreaming, it really is a tragedy for me to look around and see how, as we've progressed in science over the years, we still, as a practice matter, are on the fringes of the health industry. And I'll show this slide here, if I can get this to work right. The current vision that we have in our industry is that our society basically fears addiction almost at every level and focuses on late-stage illness. The whole discussion of addiction treatment is really restricted to end-stage illness. That would not be true of any other major illness that threatens people in our world today. And also, we have been struggling to get back into use of health funding, the mainstream of health funding, which is commercial insurance. It's getting a little better each year, but still 80% of treatment today is funded with tax money. We shrink the treatment engagement. You know, it used to be common to have 6 months or 8 months or 9 months of treatment for people in end-stage illness, and now we try and on our funding streams get it down to 60 or 28 days. We discourage recovery supports. We pay professionals poorly. We're the worst paying field of any section of health, and we discriminate against success as a society. If you don't believe that, try and find jobs for people with long-term recovery. It's an uphill fight, and our society just wants to stamp people with this. Now, we've made a lot of progress, don't get me wrong, and I'm one of the founders of Faces and Voices of Recovery. We have hundreds of thousands of people today stepping up and demonstrating that long-term recovery is a fact, and we need to accept these people and cherish them as winners in this situation. I myself, by the way, I am going to celebrate 35 years in about 30 days of recovery from alcoholism. But that's our current vision. And to start this off today, I would like to think in terms of the normal health trajectory for cancer or hyperthermia or anything else. There's an at-risk stage. Then you have early symptoms of disease. And you have then problem use of substances. And you have addiction stages. And then you have an end-stage illness. And if we think in these terms and we try and identify people that come into our care or people that we're approaching in terms of this scenario, I think it would have much better results. This is some sort of survey that was done on alcoholism by NIAAA a few years ago. Mark Willenbring did this study here, and this is a picture I keep referring to in everything that in my teaching. 70%, 7 out of 10 people of Americans really can drink safely or don't use at all, have no really connection to our illness except the people around them. 26% people are at some stage of problem use, and 4% people are dependent, and of those 1% are in end-stage illness. Now, all of our systems to this problem, and for many, many years, has been focused on this end use, this 4% of the population. And in that 4%, we really only reach 10% of the people who need professional care. 90% of the people just slip through the cracks and never get addressed. But really, for purpose of the screening that we're going to talk about today, is focused at these 26% of the people, 1 out of 4 people, who may not be showing any great problems right now, but if they have a screening incident in their life, they are better educated and better able to face the risk that they might face in their life. And so keep this percentage in mind. And so that leads us to saying that we are really marketing the risk situation rather than the end-stage illness situation. We're reaching out to people that have something to lose. They have their jobs, they have their families, they have their Social Security, and they have their health insurance. We're reaching people before they incur severe health, property, and social costs, perhaps even before they become chemically dependent. And we're reaching people with traditional health insurance in place, and that's important. Now, if this piece slide here was about cancer, we'd say, well, isn't that what happens? We educate people in school to know what the symptoms of many illnesses are, but we do not talk about addiction risk. And so this screening gives us an opportunity not just to talk about it and to start the conversation, but to have a tool to get people help when they need it. So my vision then, the appropriate vision, is for a health-conscious society that is equipped and motivated to address addiction disease at first symptoms with primary and specialty care interventions. The tool we're going to use today, SBIRT, it can be with a little bit of training done at many stages. I have taught it to EAPs at the fire department. I've taught it to teachers in school, and it's for anybody that has people, a population that come in front of them, and they might have a risk for use, and we can give them a tool that helps them successfully avoid the end stage that we're talking about. Screening, brief intervention, and referral to treatment is a groundbreaking tool, and it uses the Audit C tool that we'll be looking at that was developed by the World Health Organization. And it's a tool to advance recovery from substance use disorders. And this webinar will place this tool in focus on how treatment and recovery industry is advancing, first by engaging people at risk for substance use disorder earlier, and second by building broad awareness and consensus for normalizing the addiction experience in a whole health context. And I'm going to tell you that the market is ready for this right now. I rarely go to anywhere and people will say, well, you know, I have a cousin, I have a son, I have a mother. Tell me about that. And the conversation is so much easier to start and to deliver and offer impactful information than it was even 15 years ago, or certainly more than 30 years ago. We're going to review how this tool works. We're also going to review its potential to finally lift the percentage of people who get help from 10% to volumes associated with mainstream health issues such as cancer, diabetes, hypertension, and so on. SAMHSA is a strong promoter of this tool, and it has a couple of parts. We won't be talking about all of them today, but some of them we will. First is the use of a screen, and then what to do with information in a screen in the form of a very, very brief intervention, and then referral to treatment or referral to any other help, depending on where they are in the stages of illness. And one of the things that you're going to learn is that more than half the individuals at risk who receive SBIRT interventions in primary care alter their lives and avoid dependency. Wherever we're able to get primary care doctors' offices, emergency rooms, and hospitals, people with white jackets on to ask these questions, people pay attention. And just like when you're talking to your 10-year-old or your 9-year-old child, you may not get immediate response and say, oh, yes, Daddy, I get it, I get it, I get it. But they remember this information, and it changes the pathway of their lives. People referred to appropriate treatment succeed better when referred by a primary care physician. So one of the major objectives that I have with SBIRT is to teach hospitals and teach doctors' offices to use this tool. I conduct in Washington, D.C. lunch and learns in major health practices and give them these tools, and it really has helped a lot of people prevent them from having to get into further health issues, but gotten many people in treatment earlier when it works a lot better and it builds a solid journey for them. This tool was developed, as mentioned ago, by the World Health Organization and is currently used in 17 nations. And it's very easy to be integrated into a regular practice. Services may be provided by ancillary staff and billed under supervising physician, quite often in a doctor's office that's administered by a nurse or a nurse practitioner, and can be part of the practice without taking up the primary doctor's time. And it's most supported by insurance reimbursement. I'm giving you here the CPT code, which covers commercial insurance and Medicaid, and also the Medicare code. And you'll get this slideshow if you don't want to write those down right now, and it'll get these numbers for people that are in situations where you can bill for these kinds of services. So what does the actual questionnaire look like? And it's only 3 questions, but it offers a chance to start a conversation. The conversation can be before the first question about establishing the fact that we're measuring risk here. We're not measuring disease. And anybody should be able to take this test and see where they are on the spectrum and see if there's any risk for them down the road. And having that kind of conversation, though, when you get to this first question and the next 2 questions, you really want to stay with the exact wording because it's all scientifically tested and gives you the correct score. And the first question is, how often do you have a drink containing alcohol? And the answers are 1, 2, 3, and 4. You see that in front of you. And what this kind of is an opening to letting people discuss their general relationship with mood-altering chemical. The second question is, how many standard drinks containing alcohol do you have on a typical day? This gets into more of the depth of where people's dependence on alcohol might be getting started. And here there's a score of 1, 2, 3, and 4. And the third question is, how often do you have 6 or more drinks on one occasion? And now we're getting into the more severity of the case. And finally, this questionnaire has been adapted to be used for other mood-altering chemicals. In the past 3 months, how often have you used a mood-altering drug besides alcohol? And each one of these questions, you develop a score at the bottom, and then you total those scores. The Odyssey scoring is on a scale of 1 to 12, actually for those first 3 questions, 0 to 16, including the last question. And you add these points together. In men, a score of 4 or more is considered positive, optimal for identifying hazardous drinking or active alcohol use disorders. In women, a score of 3 or more is considered positive. For people that are over 65, it is also a score of 3 that is considered positive. Now, when I try and share that with somebody, I say, you know, on a score of 12, you have a 5 or you have a 6. So it doesn't really make them feel like they're being indicted, so to speak, with end-stage illness, but lets them feel that where they are on a scale of their experience, on a scale of their future, and also to consider how they might be alike or different from other people in their networks. So I try and say on a scale of 12, you have X, and that makes the conversation continue instead of being shut off. Now we talk a little bit about what happens after people have that information. And below are some of the common components of a brief intervention. The counselors have been shown to decrease drinking, and these can be used by lay people who have just a little bit of training, including what we're learning today. First, you want to express concern regarding their unhealthy alcohol use, and that can be said in such a way that we used earlier. We say 70% of the people can use alcohol without used safely. But 30% people, that 3 out of 10 people cannot use it safely for the duration of their life. This doesn't mean that they're end stage right now, but it shows some concern when you have a score on this test above 4 for men or above 3 for women. Feedback linking the patient's drinking to his or her health issues. As we know, alcoholism and drug addiction has implications far beyond just the direct loss of control of your life or messing up your relationships. There's solid evidence that shows the relationship between substance use disorders and every part of your body. I like to tell people, first of all, that don't look at alcohol as a real problem, or even marijuana, that those two mood-altering chemicals are what we call the dirtiest, because on their routes to doing their work in the brain, they pass through so many cells and so many organs and leave a track behind. And everybody should know this, even if they're not in end-stage illness or nothing serious. They need to know these facts that not watching their use of substances that make them feel better has influence over their overall health issues. And let them know there's education about drinking limits, and they can be found online, or you can offer to give them further information, and you can offer explicit advice on how to cut down or abstain from alcohol and other drugs. And it's useful to have a marker of checking in with people. It can be done in person or in phone. If you're in a medical facility, the practice of having a checkup 2 weeks later is normal practice for most health concerns. And if it's indicated, and if there's interest on the part of the person you're talking about, you make a referral to a specialty addictions treatment. And that's often done by simply saying, you know, your numbers are high enough that you deserve to have a professional opinion of where you stand with this risk of alcohol disease in your future, or substance use disorders in your future. And so when you recommend to people, you're saying, I'm not recommending necessarily I'm not the person that can tell you need what kind of treatment you need, but I can tell you that you will benefit from an assessment from a treatment facility in our area. And then it's good to have handy. Usually an outpatient is best for that, for doing that one-time assessment and see where they go from there. Having that information ahead of time is important. Most effective interventions are explicitly patient-centered and non-confrontational. Asking patients permission to discuss, eliciting their thoughts using reflection are several methods recommended for engaging patients in behavior change. This is a tenet of motivational interviewing, as many of you on this phone call will immediately identify. And we're on the patient side. Asking questions, asking permission to pursue the conversation is part of a conversation that is very, very effective. Longer counseling sessions are not necessarily better. This is a brief intervention, a brief test, and just doing it professionally without carrying on and trying to make a sermonette out of it is the most effective way to do. And lots of times you will not get what you feel is the right response from people. But if you've been very client-centered and very concerned about the evidence you see, and leave them in a good position to feel good about calling you back again, you will have done your job. Motivational counseling is very important. Repeated brief interventions over the phone have been shown to decrease drinking at 3 months among patients with alcohol use disorders. And I was telling you earlier about nationwide studies that show that people who have this 3-question or 4-question questionnaire are demonstrated to be at risk, but because they had this presentation, they really take steps on their own to prevent themselves from getting to further care and have good life experiences without necessity for professional treatment. That's a win-win, and I think it's really a tool that we've been overlooking its practical use in so many ways. Now, I've included here the questions for the full audit. These are questions that in a professional setting by a licensed counselor that follow up the three-question audit C that I showed you earlier. And this is just to show you, and you should maybe take a look at them. They'll be in the slideshow if you want this at the end of our presentation today. It's not recommended that you use these questions or take on a conversation at this level unless you are a professional licensed counselor, but I wanted you to see that where this goes in terms of counseling care. People will ask you, well, I have a couple of beers. Well, there's a difference between a 16-ounce beer and a 12-ounce beer. And so here's a list of what is considered a standard drink by the research that backs the SBIRT tool. And so that's handy to have sometimes. And I like to let people know that we are the science. There's no question about the medical nature of addiction disease. And I like to use this illustration of how our disease is really centered in that part of our brain, the limbic region. This is where the survival, reward, passion is the effects of substance use on our brain, and the cortex is where decisions, thinking, reasoning, and rationalizing occur. And psychological treatments are needed to overcome the powerful messages that our limbic brain takes away from the use of these chemicals. And so we have to know these two parts of the brain are essential to getting well. And that helps in my discussions with people to tell them this is a brain disease, and the brain breaks down into many parts, but here's the two main parts that are important to overcoming threats of addiction illness. Science demonstrates that heavy drinking and drug use is dangerous and treatable. And as I said, the chart I gave you before, 26% of Americans run a high risk for adverse health outcomes, social dysfunction, and end-stage chemical dependency. And if we could effectively reach this 26%, it would make a major turn in the effect of this disease in America today. This is the results of a hospital readmission study. As you may know, the hospitals are being charged for readmissions within 30 days for the same diagnosis. And we have been working with hospitals here in Washington, D.C., particularly on the med-surg wards, where often people with cardiac issues are coming and getting care, and they'll come away with tests of having chemicals in their bloodstream that interrupt that care. And what it shows is that it's in the hospital's interest to find people who have a difficulty with substance use disorders, along with their other reason for being in the hospital. And when they do, they significantly change the outcome of that care. And so this 2012 study is in much more detail, shows that when you do these tests and these tools, it has a huge effect on people's outcomes. Early interventions are really a win-win, and I'd like to advance this same use of this tool as widely as possible. It can be used in HR departments. It can be used by EA departments, EAP departments. It can be used by employers everywhere, and it has a definite effect on reducing binge drinking, on getting fewer days of hospitalization, fewer visits to emergency rooms, and fewer deaths. And this was a random study done by the University of Wisconsin over a several-year period. And they found that for every $10,000 that's invested in this early intervention with these using the SBIRT tool, $43,000 in healthcare costs are saved. This is a huge financial, but also a life-saving kind of outcomes that we could get if we get this tool to be used widely. I like to recommend getting some really good personal training on this. Here in Washington, we just got finished with the NBC Health and Fitness show, and I had 17 volunteers from Aquila Recovery who took this training from Cognito, and we did over 300 screens on the floor of the convention center. It was a health show, and this training that we get is kind of gives you a very good feeling for how to hold the conversation around giving this test. For at-risk in primary cares, how to hold conversations, and the power of conversation as opposed to lecturing. It's a 30-minute online training, and it costs $60, and they give you a certificate of completion. Cognito.com has a number of online trainings showing the conversation unfold, giving you a chance to interact with the characters on the screen. But the one I'm recommending is called At Risk in Primary Care. You'll see a course there about educating students, a wide variety of other ones. But to support this SBIRT tool that we're discussing today, you want to choose the At Risk in Primary Care subtitle under the Cognito Choices of Education, and I found that to be very good. Treatment is a process of readjusting beliefs and practices and keeping with new realities. That's a definition I really like in my own case and in all the work that I do. Nothing in our life is wasted if we readjust to what's really happening in our life and what's really happening in the science of what we work. So the recovery journey is an implementation of these updated beliefs and practices. And this journey can start with early interventions, and education does not have to start with interaction with the police department and a deteriorating home environment. Many of the interventions we have today are really tragedies of neglect on the part of everybody concerned, the people at work, people in the medical community. I am sad to tell you that so many of the people in primary health care are just not really aware about behavioral health illnesses. In fact, they have a rate of prejudice in some cases higher than the general public. So we need to carry the message that these kind of interventions really link people's behavioral outcome with their health outcome in very, very important ways. And by having these questions and this intervention, we're helping people start a journey to a much better, much safer, and much happier way of life. Here at Aquila, we sincerely believe every personal story can have a better ending. And this is a tool that we believe helps us at every stage of our work to get that done. So that's the presentation. I hope that you found this useful. I'm open to answering any further questions. I think that as you get into this and as you practice it, and I believe in role-playing, by the way, that you will find ways to of your own to use this practice in the life, whatever profession you're in and whatever relationship you have to this disease. It's very malleable to the situations in front of you, as long as you have in your heart that willingness to reach out to people who at some point in their life are going to face trouble with substance use disorder. So thank you very much for your attention, and thank you much for being interested in this topic. I think it has a potential to really change how America addresses behavioral health in general and substance use disorder in particular. And so I'll take any questions that you have. And thank you again.
All right, thank you, Johnny. If you have any questions, you have a chance to type your question in your computer now, and we can go ahead and get those addressed.
Kathy, how do people get a copy of this slideshow? I'm particularly concerned about those people who might want those reimbursement codes for doing this this questionnaire.
We're actually going to send a copy of the PowerPoint out via email to those that attended. I do see a question here that popped up. There's a question, can this tool be helpful while the patient is in recovery?
Does this test useful for people that are already in recovery? Is that the question?
Yes.
It is as a couple of reasons why it's important to SBIRT be spread to as wide audience as possible. Number one, people in recovery are beginning a journey, and that journey is not a fixed length. It lasts the rest of your life. So for me in recovery to learn about this tool as an assessment of where I am when I'm in doubt, sometimes that when I'm on the right road, that's important to have a little check on myself. But it's also good for them to know there are tools that they can use in their network, and network building is an important part of recovery. And this tool can be useful in building your network.
Okay, and I see another question that pops up. Do you recommend the SBIRT free online course through Medscape that addresses the basic principles of SBIRT, as well as coding and reimbursement for the implementation of SBIRT in practice?
Yes, I do. It's very similar to the Cognito one I recommended, but that one is also a very good one, yes.
All right, and Johnny, it looks like those were the only questions that I got. Thank you again for doing our first webinar of 2017. Our next webinar will be on February 8th. It's going to be part 2 of our SBIRT series, and this will be with drug-free Duval. And there's more information to come with that. But with that, thank you again, Johnny, and everyone have a good afternoon. Thank you for joining us.
Thank you.
Bye-bye.